To introduce our first speaker, Dr. Jennifer Neal. She's a GP and senior lecturer at Monash University, where she lectures on domestic violence. She works as a GP educator on domestic violence for the Harmony Study, a randomised controlled trial being led by La Trobe University and the University of Melbourne. She's the chief investigator in a research project regarding domestic violence education and has recently published an article on domestic violence and COVID-19. So take it away, Jennifer.
Hi, everyone. I'll just show my screen. Oh, what happened? Oh, sorry, I did something wrong. Can you just give that back to me again, the presenter to me again, so I can show my screen? Or can you see it? Can you see that?
Yep, we can see it.
Oh, good. Thank you. Fantastic. All right. So I'm Dr. Jennifer Neal. But this is basically what we're going to cover today. We're going to talk about how to recognise cases of domestic violence, how to know how to ask about domestic violence, how do we then actually respond once someone discloses that they are a survivor of domestic violence, how do we safety plan, referrals we're going to talk about a bit later on as well. Briefly, we'll touch on managing perpetrators, but also I'm going to talk a little bit about managing domestic violence in a pandemic. But I just want to start by just illustrating a case. This is actually a case that I've had recently. So Linda, my patient, has been known to me for quite some years. She's got a rather challenging child with ADHD who's about 7. And then she, about a year ago, had her second child. She often brings her kids in for all sorts of different things, but she's never really come in to me herself about anything. And it wasn't until recently that I found out that her husband had actually so it wasn't until recently that I found out that one of my colleagues had actually referred her husband to a men's behavioural change program because there'd been some issues with domestic violence. She came to me in amongst the COVID pandemic, saying to me that the violence had massively increased. He had actually attempted strangulation and had beaten her up on a number of occasions. One of the occasions that one of the kids had possibly even witnessed something to do with it, although mum wasn't really sure whether she'd seen anything, but was worried she might have. She was feeling very, very concerned for herself, but didn't really want to leave because the problem was, like we all were, they were stuck at home with each other. And she really didn't know what to do or where to go. So I saw her on a number of occasions, and each time we talked about her options, and we obviously safety planned, and we're going to talk a lot more about how to do that later on. And eventually, after about 3 visits, we managed to talk about the fact that going to her mum's house might well be an option. And so she decided that together we would contact her mum, who was also a patient of my clinic, who I also knew. And we would actually contact her mum together and actually see whether that's something that she would consider having her go there. Her mum had a slightly difficult relationship with the family, given that the grandchildren are quite, the 7-year-old was quite difficult to control. But mum said, no, that sounds fantastic. She should definitely come to me. That's a really good idea. And so we organised for Linda to actually leave and to go to her mum's house. Her mum set it all up. Her mum looked after her. We also involved domestic violence agencies to give her some counselling and support during this time as well. And she found that really, really helpful to have that support as well. She knew, however, as we know, that the time of leaving is in fact one of the most dangerous times for a victim. And so, you know, this could have been a really difficult time for her. Fortunately, it's worked out. And she actually feels really safe at her mum's house now, where she still is, and she feels like she's getting a new lease on life now. Now, look, we're not going to go over stats for ages and ages, but I just want to highlight the fact that domestic violence is super common. It's 8 to 28% of women presenting to general practices have been survivors within the last 12 months. I mean, that's a huge amount, really, when you think about the number of female patients that you see in a day or in a week. Nearly 1/3 of all women have ever been survivors in their entire lifetime in Australia and globally. And each week, one woman is murdered per week on average. And the reason I talk about women as being the victims is because this is in fact very gendered. There are far more women who are victims of domestic violence than males. And in fact, often when women have been perpetrators of domestic violence, it's in fact because they are in self-defense rather than because they are initially the perpetrator. So I want you to just think about, in the last year, or sorry, this year even, since COVID, how many domestic violence survivors have you seen? Now, I'm betting, because when I do these workshops with people, usually people say either 0, 1, or maybe 2. And I'm telling you, it's a lot more than that. Really, it's because we're actually just not asking. We'll just do a little bit of terminology. Now, domestic violence is different than family violence, but I'm going to use those things fairly interchangeably. Domestic violence is obviously within a household, and family violence is within a family. And family violence can be either intimate partner violence, child abuse, elder abuse, sibling abuse, but we're going to focus really on intimate partner abuse here. Now, there's lots of different types of abuse. You probably already know quite a lot about this already. Where there is physical abuse is obvious. We all know about physical abuse. There is psychological abuse as well. Look, psychological abuse can take many different forms, but often it takes the form of someone being belittled and told that they're terrible, gaslighted, that sort of thing. Social abuse, look, I've seen social abuse, and basically I had one patient that the partner would not let this patient actually socialize with anyone unless he said it was okay. So only his friends were all right. She was not allowed to see her family. She was not allowed to see any of her friends. And in fact, this particular person also used technology abuse and actually used the phone to track her so that he could work out where she was going, so that he could tell whether or not she was actually visiting family members or not. So, I mean, technology abuse is becoming more and more of a big means of abuse. Sexual abuse, yes, we obviously will know about, and financial abuse. Again, I've had a patient who earned far more money than her husband did, but because of the relationship that they were in, and he had so much power and control over her and exerted that control over her, he was the only one who had access to the bank accounts, and she had to put all her money into the bank account. And then what would happen is that he would give her a very, very small sum each week. I think it was something in the order of 4 or 5. And that's an example of financial abuse. Very quickly, again, we're just going to go through some common beliefs. Family violence only happens to a certain kind of woman. Is this true or false? Fact, family violence occurs all socioeconomic levels, races, educational levels and backgrounds. And, you know, violence may well be affecting our peers and our friends. Sorry, I'm just having some technical problems. There we go, all good. Most women are abused by strangers. Fact, most women who experience violence are abused by people they know, often people that they love and they trust. In Australia, 1 woman murdered per week, and the majority are actually murdered by either their partner or their ex-partner. When I say completely different to men, men are usually actually killed by other men. So a woman will be safe when she leaves her abusive partner. A lot of people will believe that, but in fact, often the violence actually continues and often will even increase after a woman leaves. In fact, a woman's greatest risk of actually being murdered is when she has just left. Men are naturally violent and cannot help themselves. In fact, no. This is enabled by norms around masculinity. So what I want you to think about is, if someone is in their house and they're perpetrating domestic violence, they're beating up their wife, and then a neighbor comes and rings the doorbell, what do you think happens to the violence? Is it because he's out of control with anger? No, he has complete control over it. He will go and answer the door, and the violence just stops. That's why violence doesn't occur at Chadstone, it occurs in the privacy of someone's own home. Women are violent too. Well, actually, yes, women are violent too, but when compared to men, they are far less violent. And when they are violent, they don't really tend to cause many injuries and are far less likely to result in murder. And often it's in response to the violence committed towards themselves, and it's actually self-defense. Women who experience violence at the hands of their partners deserve it. If she had acted differently, it would not have happened. Well, of course, it is never a woman's fault. And I think it's really important for us to believe women when they tell us about domestic violence, and for us to be able to reassure them and tell them that it is not their fault that it occurred. So in general practice, who are we going to ask? Do we ask everyone or just some people? Well, I tend to ask people that have either physical symptoms that make me concerned or psychological symptoms. So physical symptoms, obviously things like acute injuries or fractures. It might be that they've got chronic pain, chronic headaches. They might have a pregnancy that's unplanned or an STD, vaginal discharge. Emotional symptoms such as anxiety or depression. Look, I do a lot of mental health in my practice, and I screen every female that comes in with a mental health problem for domestic violence. Drug and alcohol problems, eating disorders, suicide attempts, PTSD, accompanying partners, really important. So this is just an example of an accompanying partner. Now, have you ever had that patient that the female patient only ever comes with her partner? Every single time she comes with her partner, and she doesn't do much of the talking, he does a lot of that talking. That's a really big red flag for me for domestic violence. Look, I mean, of course it may not be, but it is a red flag for me that this is a controlling partner. Now, as GPs, we are in control of our own consulting room, and really the only way for us to actually be able to ask her is for him to leave the room. So my approach to this is to say, I always like to talk to my patients alone at some point in a consultation, and I'd like you to just go out now and wait in the waiting room. We'll get you back in at the end in case you've got any questions. This, it's possible that they might refuse. I've never had anyone refuse yet. You really cannot ask her if he is present. So in general, women do want to be asked about domestic violence. Most women actually want to be asked, but have found that they rarely ever are asked. So only 1 in 10 doctors actually ask because there are so many barriers. Maybe it's because we go, oh, I don't want to open that can of worms because I've only got a 15-minute consult and I'm already running 10 minutes behind. A lot of the time, from all the educational sessions I've done, I've actually found a lot of the time people say to me the main reason that they don't ask about it is because they're not sure what to do with it when they actually disclose it. And we're going to talk about what to do about it tonight. Fear of offending the patient, belief it's a private matter, or fear of the perpetrator. And there's a lot of barriers to disclosure on her behalf as well. She's worried that the doctor's going to judge her and is going to think that it's her fault. She's also afraid of her abuser and that this might not be confidential, and that in fact the doctor might say something to the abuser. But also it's quite common for women to actually believe that abuse is normal, to feel like maybe he'll change in the future, and also just fear judgment. So how do you ask? So what I usually do is I like to assure the woman that everything is confidential. Now, I don't obviously say that in every consultation, but when I talk to adolescents and when I talk to domestic violence victims, I always like to assure them of confidentiality because it's really important to them. Then I ask something like, how are things at home? How are things going at home? And then sometimes I'll say something like, many women experience problems with their partner, or many women experience domestic violence. Is this happening to you? And by phrasing it like that, it's saying, this is something that I've seen before. I'm not going to judge you. I'm not going to get freaked out by anything you can possibly tell me. It sort of in some way normalizes it so that she sort of feels more comfortable to disclose. And then I might ask after that, how are things going on with your partner? Do you argue much? What happens when you argue? Has he ever been violent towards you? Do you feel safe at home? And that's a really important question. Do you feel safe at home? And when you're doing a safety assessment, one of the best ways to tell whether a woman is safe at home is her own judgment about whether she's safe at home. She is the expert in her own safety because she's been living this probably for years, and she is a very good judge as to whether or not she is currently safe at home. So this is basically a bit of a framework of what to do when a woman discloses to you. So the first is to listen, to hear her story. Don't rush, take time. These are the consults that you go, sure, I'm running behind, but goodness, this is so important. She may, if I shut this down right now, she may never disclose to someone again, or it could be years before she actually discloses again. So this is really important that I actually take the time to listen to this. And then to inquire, to find out what her needs and concerns are, to validate her. So that's the bit I was talking about before, where we believe her and we say to her, it is not your fault that this has happened to you. No one deserves for this to happen to them. It is not okay what has happened. And I often find actually calling it out for what it is really, really validating as well, to say this is domestic violence. It might have gone through her head that that's what it is, but she might not fully have accepted and realised that in fact that's what it is until you say it. So then we do a safety assessment, we'll talk about that in a moment, and supports including referrals. So Jill, this is another case that I've had recently. In fact, Jill has been, I didn't meet Jill until a telehealth phone consultation because of COVID, a few weeks into the whole lockdown thing. And so I'd never met her before. She's a social worker, and she said to me, I'm living with my abusive son. It's really, really difficult, but I don't know what to do because, you know, I've tried to contact a few domestic violence organisations and I feel like no one can help me. And so I sort of went into it a little bit more. And he was doing some absolutely awful things. He was throwing furniture at her. He was he was actually physically beating her up. I was actually becoming quite concerned for her safety. And I was actually to the point where after one phone call, and she said, no, I do feel safe tonight, and I believed her in that, but I have to say I called her the next day just to check how she was going, because she didn't want to leave, and because she didn't want to put him out on the streets because he had nowhere to go, because he was actually only just into adulthood. And she didn't want to leave because that was her house. And she said, I still love him. I just don't know what to do. And the key here was me understanding why she was staying and why she hadn't left. And I told her, I can totally understand why you're staying, because you love him. And I can see how difficult that must be for you. That must be absolutely horrible. And this was what the people who'd already spoken to her didn't do. She felt like they were just putting so much pressure on her and not understanding her situation, that in fact that gave her the ability to feel like she actually thought that she could actually do something about it. And so we talked it through, and we agreed that what should happen is that she needed to call the police if she felt threatened. And so that's exactly what she did, because the next day she felt that things were heating up, and she called the police, and they took him away and have charged him. And there's an intervention order out now, and she is now safe. He hasn't come back since that circumstance. But it also just goes to show both of these scenarios that I'm telling you about go to show just how much COVID has impacted on domestic violence, because both these cases, the reason it had escalated was because they were shut down in lockdown with their abuser. So the abuse had increased, and that's a pattern that we're seeing everywhere. And I'll tell you a bit more about that later on. So why do women sometimes not leave? And it's really important for us to understand this. So there's a few reasons. One, fear that they might be killed or that the violence will increase. And do you know what? This is a very valid fear, because it may well be that if they leave, that the violence increases, or in fact that they're murdered. So we need to be able to help them safely leave, and that's where domestic violence organisations are, so well set up to be able to support women through that, and also us as GPs through our safety planning processes as well. So fear for their children, what happens to the kids? Do I take them? Don't I take them? Might not have a house. And this is a really real issue, because sure, they might be able to go to a domestic violence shelter, but that's not a long-term solution. They may be able to stay there for a few weeks, maybe a couple of months, but where do they go after that? They may not have access to any money. And we all know in this world it's very difficult to get by without any money. They may fear that no one will believe them, because that may be what's happened to them in the past. They may have told friends or family what's going on, and people may have in fact blamed them and said it's their fault because they're not being a good enough wife, or it's because they just need to do what he says because of, the patriarchy is meant to rule, the women and all that sort of thing. And also the hope that he might change. And look, I've seen a large number of women that's the reason that they haven't left, is because they actually hope that he's going to change, that look, it's happened a few times, but things are pretty good now. Maybe it's going to stay good and it's not going to happen again. So when we're doing a safety assessment, what we need to find out about is the violence escalating at the moment? And in both those cases that I've talked to you about, the violence was escalating. Have they ever been threatened with a weapon? Now, you could ask about weapons in the house, but in Australia, it's almost irrelevant, because unless you're rural and you have guns lying around, in fact, everyone has weapons in the house, because what is the most likely weapon? Hands are the most likely reason that a male kills a female partner, with his hands. But the second most likely way of being killed is by a knife. And knives are in everyone's kitchen. So yeah, everyone has access to weapons, unfortunately. Strangulation. We know that there is a definite correlation between strangulation and the probability of getting killed. So strangulation is a massive red flag in terms of safety. And I've mentioned leaving is the most dangerous time to be killed, but when you're pregnant, it is a very dangerous time for the violence to escalate. So how do we then safety plan? We've assessed safety, and as part of that, like I said before, saying to her, do you feel safe going home tonight? Do you feel safe at home at the moment? If she doesn't feel safe, we really need to get her out of that situation now, and that's where I'd be involving in Victoria. I've got an organisation called Safe Steps that I use, and there will be the equivalent in New South Wales, and I'm sure you'll hear a bit more about that a bit later on. So I would call that organisation to help get her out, to find a bed at a shelter ASAP, so that we could get her out of that situation, and possibly even notify the police if she's willing to do that too. I encourage women who choose to go back home, don't look at them and go, they're crazy. Treat this like a chronic disease, a bit like a smoker. So when you see a smoker, and the smoker, you have the conversation about stopping smoking, you don't say to them, oh, well, don't come and see me next week if you haven't stopped smoking. In the same way, you would never say to a domestic violence victim, well, if you don't leave, don't come back and see me. You really got to leave if you're going to come back here again, or anything like that, because I know people have done that in the past. This is like a chronic disease. If she's going back to her partner, remember, you have actually done a lot. One, you'll have done safety planning, but two, you'll have provided a safe place for her to come back to in the future. I had a colleague several years ago who said to me, I had this domestic violence victim come and talk to me, and she went back to her partner, and I just feel like we achieved nothing. And I said, no, you have achieved so much, because next time when things get really, really bad, she's going to go, oh, there was that GP who was non-judgmental and sympathetic, and I know that I could go to that doctor. They believed me and listened to me. I could go back there for help. Okay, so creating a safe place is really, really important. So what we do when we do safety planning, there's a few things depending on the circumstance. It might be that she needs some money set aside somewhere, and we talk to her about, does she have access to money? How much money does she have? Can she get a separate bank account, or can she put some money aside somewhere safe? Could she get some copies of important documents? I usually say copies rather than the actual passport or birth certificate, because it's really obvious to the partner if they're gone, and then it raises suspicion and it may escalate the violence. a bag of clothes. And again, this needs to be put away somewhere where he is not going to notice. So it might be that you say, get a bag of clothes, some money and some photocopies of your important documents. And you need to tell one of your neighbours or one of your friends or family members who live close by, and have those things sitting at their house ready waiting for you in case you need to leave. Now, let's hope that you never feel like you have to leave in a hurry. But if you do, you're well set up. So I encourage them to have at least 2 people that know about what's going on, so that if they need to leave in a hurry, they've got at least 2 options. You can even have safe words with these particular people, or code words. You could send a text with a code word to them that lets them know that you need to be picked up, for instance, or that you're about to come to their house, for instance. The other thing is with telehealth, and we'll talk a bit more about that later, colours can be a code word, so either to friends and family or to you as the doctor. Having spare keys for the house, and always as safety planning, you must tell her that she needs to call 000 if she is threatened. She should not be calling a domestic violence organisation if she is under threat, because she needs right then and there to have the police attend. So 000 if she's threatened. And then we'll talk a bit more about the domestic violence hotlines later on. But she needs to think it through. If things are getting worse, where's she going to go? How's she going to get there? And are the children going to come as well? Now, these are some domestic violence phone numbers. Now, these obviously, you're going to talk some more specifically about your area. Now, when I educate some of the people in parts of Melbourne, just in one primary health network in Melbourne, there's a list of about 10 to 15 different phone numbers for different services for different purposes. So when I wrote my recent article in the AJGP on domestic violence and COVID, I in fact even there recommended using health pathways as a way of actually working out who is the best person, which is the best organisation in your area to contact. So how do we manage perpetrators? So perpetrators, look, how do they present? Like victims, they come from every socioeconomic, they come from every race, they come from every background, every religion, and the same as victims. So how do they present? Well, most often you won't even know. In fact, a lot of the time, perpetrators will actually be said by their friends and family to be, oh, isn't he such a nice guy? Isn't he a lovely person? But they don't realise what's actually happening in the home. So what kind of men are perpetrators? Any kind of man could be a perpetrator. That, of course, does not mean all men are. Men's behavioural change groups. What is their role? So the problem with domestic violence is we know in general that things usually repeat themselves and don't often change. If someone has got a pattern of being violent or controlling of their partner, it is very likely that that control is going to continue on in the future indefinitely. Now, there is some hope in men's behavioural change groups. Now, men's behavioural change groups, they're run all over Australia. There's often quite a waiting time to get into them. They usually run for around about 12 weeks or so. And basically what they're about is they're basically teaching men to be respectful of women. It's what it's about, is really changing that the societal norm that women should be able to be controlled by men. And so do they work, I guess, is the most important question. Well, 30 to 50% of partners of the men who attend the behavioural change group say they felt safer when their partner has attended. Now, that does not mean that the violence has stopped. That just means that in some way they have felt safer because of the group. Interestingly, it's actually quite a common time for women to actually leave their partners. Now, one of the reasons for this is because they feel like, well, I've tried everything now, but the violence continues. So therefore, you know, that was my last ditch effort. I really thought he might be able to change and he hasn't, so I'm going to leave now. Now, the other reason is because they're feeling a bit safer, they actually finally feel like they can actually leave because they feel like it's unlikely that they're going to be murdered if they actually leave. So that's one of the reasons that women often do leave around that time. I've had a couple of patients go through men's behavioural change groups, and both relationships have ended up in intervention orders in the end, unfortunately. But there is, look, you know, there is a small chance that things may actually improve. So as a GP, we often manage families, don't we? I mean, you know, I've managed victims and also their husband. Like I had a couple who she brought him into me. I'd been managing her for quite some time. I'd seen him about his depression. I heard just physical stuff. I'd never asked about domestic violence before, and she brought him into me and said, you need to do something. He's sometimes being violent. And he goes, yes, I admit it. I sometimes am being violent, and something needs to change. What can we do? So he was one of the ones that I organised to do the men's behavioural change program. But then becomes the issue of, well, what do I do? I now have a victim and I have the partner, and it's very, very clear in the RACGP White Book that we should not be managing both the victim and the partner at the same time. It becomes very conflicted. It could be potentially very, very dangerous, because what could happen is that we might actually inadvertently say something that the other partner has said to us. So in this case, what I did was, after I'd referred him to the Men's Behavioural Change Program, I asked him to see one of the other GPs as an ongoing instead of me. And I continued to manage her, and then obviously went into the domestic violence a bit more. And she's one of the ones that ended up with an IVO, and they've separated. So then came COVID. So what's COVID done? Well, I won't go through all these stats, but all these stats say is that we know that the number of calls to helplines, searches on the internet have all increased. Now, that is probably even the tip of the iceberg, because when you're stuck home with your abuser, it may be actually very difficult to actually be searching for things on the internet or making phone calls to hotlines potentially. So this is the paradox in domestic violence. So, you know, we're saying to people, stay at home. It's safe to stay at home. But in fact, for survivors, staying home may not be the safest option. We know that abuse is about power and control. Like I said earlier, it's not about anger. It is about power and control. And when forced to stay at home with your abuser, the abuse can increase. So this leads us to telehealth. Well, look, telehealth may potentially increase the ability of a victim to reach out to a GP. So it may actually be very, very helpful, because it may be that they're not able to get out to see you, but they could actually contact you via telehealth. So I've had a couple of situations where I've had people talking to me on telehealth that I really don't think would have been able to get to me otherwise. But at the same time, when you're stuck at home with your abuser, it may well be that you're not able to actually talk online safely. So as a GP, if you're wanting to ask someone about domestic violence over telehealth, don't start with a lovely open-ended question like we like to. Start with a closed yes/no question about safety. Are you safe to talk? That's a yes/no question. So she can say no. Is it safe for me to ask you how things are going at home? Yes, no question. She can say it is or it isn't safe for her. So this is how we should begin our conversations about domestic violence. And then, of course, if she said she's safe, then you ask in the same way that you would normally ask. It's really, really clear with disasters that most disasters, there has been an increase in domestic violence following, and often this increase in domestic violence lasts for at least a year. And there are many, many examples of this all over the world. Now, the issue for COVID is that because this is such a prolonged disaster, and look, it's not finishing anytime soon. I'm from Melbourne, and right now we're locking things down more than we were before. It's not finished anytime soon. So it's very likely that the increase that we're seeing in domestic violence rates is in fact going to be quite prolonged and pronounced. We're yet to know about the stats in terms of murders and things because it's actually just too early to tell. But look, you know, it is very concerning, and really this is like our hidden epidemic, our hidden pandemic is domestic violence. And look, any patient that you think, goodness, I was a bit worried about her in terms of whether she was a domestic violence victim and she hasn't been in contact for a really long time, or that child hasn't been to see me for a really, really long time, and I've always been a little bit concerned about whether maybe something bad was happening at home. It may well be that those people are not coming to you because they're actually in situations that they can't reach out for help. So you may need to potentially reach out to people if you can think of people that you need to reach out to. So I think we're going to do some questions at the end, but I'll hand back over to May.
Thank you so much, Jenny, for that. That was great. I think in the beginning the connection dropped out, so I'm just going to reiterate that Jenny has joined us from Monash University, and she's a lecturer on domestic violence and is currently working on a randomized controlled trial as a chief investigator looking into domestic violence education. And as she mentioned, she's recently published on the topic and COVID-19 in the AJGP. So thank you so much for joining us. That was a great, that was a lot to go through in such a short period of time. And yes, so in terms of questions, we'll save them till the very end. Next up, we've got Christina and Marae, who are going to tell us a bit more about the domestic violence services that we have available in the Southeast Sydney area, as well as how to make a referral to a safety action meeting for women. Just a bit of background, Christina has worked for Southeast Sydney Health Service for 19 years as a social worker across women's and children's health, including as a domestic violence counsellor and also at St George Hospital Paediatrics and Maternity Services. Marae is the Southeast Sydney Local Health District Violence Abuse and Neglect Coordinator, and she's working to improve the health response to these issues across the LHD. She's also a social worker with previous experience in working in child protection, homelessness, and the critical care services at Prince of Wales Hospital. So thank you, Christina and Marae.
Thank you, May. I'm just going to share my screen now. Okay, so thank you for having us. We're pretty excited to be talking to a bunch of GPs and GP nurses. It's pretty exciting for us as it's definitely an untapped kind of link in the chain in terms of our hospital work and community health work. And thank you, Jenny. You've really provided a really great overview of everything. We're going to delve a little bit deeper into intervention and what that kind of looks like at a more local level. So I'd just like to reiterate that the aim of intervention in domestic violence is not to get the patient to leave their abuser or fix the problem. That's not necessarily your job. It might not be the right thing to do. It might not be safe for them to leave. There's a whole range of, problems there. So what you should be focusing your intervention around is increasing their safety, empowering the victim, providing support and information about resources, and letting them know what their options are. So by providing them with options, you're empowering them to make a decision based on, the information that they have and where they're at in their journey. We'll take this little step back and look at the dynamics of domestic violence before we look at risk assessment again. So at the top of this image, we've got an argument. We all fight, we all argue in our relationships, and it can be a really healthy part of relationships. You know, we can have a little disagreement. We both have our voices heard. We both express what we need to, and hopefully we move forward and create intimacy as a result of, you know, conflict resolution. But what we see in domestic violence are issues about power and control, as Jenny mentioned. So through an array of tactics, violence, belittling, fear, intimidation, physical violence, threats, the perpetrator has shifted the balance of power, and he now holds the vast majority of rights in the relationship. So what the victim wants, what they need, what they're entitled to, safety, freedom, to be able to go and see who she wants, wear what she wants, spend what she wants, has been diminished through his tactics of violence, and that continues to get diminished over time. But DV is not just about the couple. We also are starting to really look at social responses, both to the victim and to the perpetrator, and their role in allowing for domestic violence to continue. So, for example, do the neighbours call the police when they hear things escalating? What message is that sending to the victim? What message is that sending to the perpetrator? If she attends the emergency department asking for, you know, with concerns for her mental health, and no one talks to her about, you know, what's happening at home, is she safe? She might get pathologized, told that she needs to go to the GP for a mental health care plan, when in reality she's considering leaving her, you know, very violent partner, and is, you know, petrified, anxious, not sleeping. And so are we providing a response to both victims and perpetrators that are just continuing these issues, or are we actually intervening in opportunities such as, you know, a GP appointment? So we'll just look at risk factors again. I know that Jenny has mentioned these, but we just wanted to look at them in a little bit more detail. So risk factors for the victims. So pregnancy and new birth, as Jenny mentioned, is a really high risk period for a number of reasons. So if you consider 1 in 4 women have experienced physical or sexual violence in an intimate partner relationship since the age of 15, the women that you're seeing, say, for example, through the GP Cares shared care program, that should be highlighting to you, you know, potentially 1 in every 4 of those, you know, women that you're seeing have potentially experienced it or are experiencing domestic violence. Depression and mental health issues, both for the victim or for the perpetrator, and drug and alcohol issues, again, both by the victim or the perpetrator, can indicate that things are escalating, things are, you know, higher risk. If the victim is heavily isolated, if she's not connected to any services, if she's not, you know, doesn't have any support, she's not talking to anybody, that's also a higher risk factor for the victim. Jenny already talked about recent separation within the relationship, and this being the, you know, highest risk period. So that can, most people know that, and now that information is pretty well known out in the community, and it might be used by the perpetrator to instill fear for the victim to consider leaving. Access to weapons is obvious why that's a risk factor. Sorry, what happened? Threats to harm the victim, children, pets, is also a high risk factor. So strangulation, Jenny mentioned, we did some training recently, and someone said, yeah, but, you know, how common is that really? So in 2016, legislation changed in Queensland, and it was changed to make a non-fatal strangulation a standalone offence, punishable by up to 7 years imprisonment. In the following 12 months, almost 800 people were charged with it. That's 800 who have, you know, attended the police, and the police have actually taken action through the court system. So that number in reality within the community is a lot higher, and they've done a lot of research recently around traumatic brain injuries as a result of strangulation and repeated strangulation. So often women won't have just experienced one experience of strangulation by their perpetrator. It would have been something that they've been experiencing over time. Stalking, so if the perpetrator is using either technology, which is what we're seeing a lot more of, unfortunately, so using tracking devices, location devices on phones to control people around where they go, who they, where are they going, are they going where they said they were going, and obsession and jealousy issues as well. I will hand over to Christina now, who will talk a little bit about these high risk kind of situations.
Thank you, Mim. So my position in South East Sydney Local Health District is the Safer Pathway Health Clinician. So my position came about because of some legislative changes that happened in New South Wales. So Safer Pathway is basically the recent legislative changes where there were proposals for a more coordinated response to domestic and family violence. And that is because, as Jenny has told us already, that there is still one woman on average a week dying through domestic and family violence. So that to me is still staggering that in 2020 that we still have that statistic. So really Safer Pathway is about reducing serious harm, reducing homicides. Safer Pathway really looks at two levels of threat. So one is at threat and one is at serious threat. And your safety planning with your patient will depend on what level of threat you have assessed that person to be at. And that's based on your professional and clinical judgment. There's no sort of right or wrong answer with that. I guess when you look at safety planning, you need to know that leaving the home, as we've discussed, it might not always be possible and it might not always be what the victim wants to do. And going to the police in the same way might not be what the person wants to do or what is necessarily safer at the time. So I guess how do we know what to do in which situation, whether it be at threat or at serious threat? So at threat would be, I guess, looking at the risk factors that are concerning and could they escalate. They're a threat, that are a threat to a victim's life, health, or safety due to domestic violence. And I guess providing the appropriate support, either directly or making referrals, and doing some basic safety planning so that if things do escalate, they do have a plan. At serious threat is where we look at multiple risk factors that are current. And current is really important because there may have been things that have happened in the past that might make someone at threat, but serious threat really involves things that are happening right now that threaten the victim's life, health or safety, and they require urgent action. And so those risk factors, as we've shown on the previous screen. And what we need to do in that situation is assess and address the victim's immediate safety needs. We need to think about, do we need to report to the police? Putting them in touch with the domestic violence helpline, looking at emergency accommodation, advice, and linking them into counselling, and linking them in with Safer Pathway. So that would be sort of myself or the Safety Action Meeting Coordinator. Safety Action Meetings are a new part of Safer Pathway. So as well as the two levels of threat, there are the Safety Action Meetings. Safety Action Meetings are basically agencies and services that share relevant information in order to prevent or lessen serious threats to life, health and safety of victims of children. So they're a fortnightly meeting in different local area police commands. They are chaired by senior police officers and they're attended by domestic violence police officers, New South Wales health representatives, including mental health and drug and alcohol. They're attended by education representatives, Department of Education, probation and parole, child protection reps, and the court assistance scheme. So in line with what Safer Pathways was trying to do, we're trying to get together for a case conference in each district to talk about what are the most serious incidents that have happened in that fortnight, and what can we do to address the immediate concerns. So that might be something as simple as moving the person. So sorry, one of the agencies I didn't discuss was New South Wales Housing. Now, if someone's feeling unsafe in their home and their ex-partner knows where they're living, through that meeting, it's really important to know that New South Wales Housing can very easily transfer somebody, and it's only through knowing through the police and through the interagency discussion that that person's at risk that housing can then take those steps to do that. Another way to assess whether somebody is at threat or at serious threat is by the use of the Domestic Violence Safety Assessment tool. And I know that May has put this on your Health Pathway site, so you can access this. And this is what the police use to assess risk, to assess threat, I should say, when they go out to a domestic violence incident at a home. It's a standardised assessment tool. It provides consistency in assessing level of threat, and it relates to those known indicators of harm. So threats to harm, strangulation, all the ones that we discussed before, sexual assault, weapons, harm to pets or threats to harm pets and children. And there's several questions, and where somebody has answered yes to more than 12 of those questions, that would deem them at serious threat. Under 12 would be at threat, but it does allow for us to use our professional and clinical judgment as well to upgrade that person to a serious threat. And so if somebody is at serious threat, they can then be referred into that safety action meeting and be discussed and linked in with the appropriate supports, and that those immediate needs can be addressed. Just move on to the next one. Something that I think people are really concerned about often is about, am I allowed to share this information in regards to domestic violence, and is this confidential? With the changes to legislation, there was included Part 13A, which is an amendment to the Crimes, Domestic and Personal Violence Act, to allow information sharing and improved integrated responses to domestic violence. So that legislation addition allows us to share information where there's a reasonable belief that there is a serious threat to a victim's life, health or safety due to domestic violence, and we need to do something about that. So that does give us a little bit of a sense that we are covered by that legislation, that we don't need to fear some kind of legal repercussions for sharing that information, because the matter is that serious that we need to. And really, we can't address DV properly unless we, collaborate and we have all those pieces of information. Of course, when there are children involved, there is Chapter 16A of the Children's Young Person Care and Protection Act, which is a little bit, it gives us a little bit more freedom in sharing information, because the child does not have to be at serious threat. It's just where we have concerns about risk of harm to a child. So there's those two parts of legislation.
And so then we just wanted to touch on AVOs. So obviously an AVO is just a piece of paper, really, telling somebody what they can and can't do. But there are two ways of applying for an AVO in domestic violence, which I'm not sure that many people are aware of. So if the police attend an incident and have serious concerns for the victim, they can take out an AVO with or without the victim's permission. So she might be saying, no, I want him to live here. I don't want anything to happen. I don't want to press charges. The police may still override that and decide that they at such serious risk that they need to be under protection. If the victim still doesn't want this to happen, she can go to the court on the court date that the AVO is set to be heard at the local court and request to the magistrate that this, the AVO either be varied or be taken away completely. So within an AVO, there are set conditions, and there's a whole range of different conditions that can be put in place, from as limited as they must not hurt or intimidate the victim, to things that like they're not allowed within 100 metres of their property, they're not allowed to have contact with the children, and there can be a whole list of different conditions put on an AVO. If the police haven't attended an incident and someone just wants to take out an AVO because they're concerned about their safety, they are entitled to do that. What they need to do is have a little bit of evidence, and they need to go to their local court and they can request for an AVO to be put in place. Now, an AVO is not a criminal charge. It might be related to criminal charges, but having an AVO taken out against you as a perpetrator does not show up on your criminal history alone if it's just an AVO. But if they were then to breach that AVO, so they were to do something that was against one of those conditions that were listed on the AVO, then we're looking at criminal charges, and that would then come up. So that's another important thing for someone to realise. A lot of victims say, I don't want anything bad to happen to him. I don't want him to have any criminal history or anything. An AVO is not making that happen. But if he breaches that AVO, now his, the consequences of his actions, are something that he's going to have to live with. So it's just important for people to kind of be aware of what actually an AVO looks like. Now, we were going to talk about a case example, May, but I'm not sure if we're going to have time to do that or not.
I think that'll be great. I think it's always great to learn through cases, and I think we're still good for time. So let's go ahead.
Okay.
Excellent.
All right. Thank you,
Christina.
May. Thanks, Mim. I'm going to talk about Amy, who is a 28-year-old first-time mum. You are her GP, and you provided antenatal shared care appointments through her pregnancy. She's come to you for her baby's 6-week vaccinations. Her past history, just some points on her past history. She has experienced depression as a teen, but she's been well since. She has little support from her family, as they live in Victoria, and she and her husband moved to Sydney when he got a job a year ago. She doesn't have many friends in Sydney, apart from a few work friends who don't have kids. So her current presentation to you as her GP, what you notice about Amy is that she doesn't seem herself. So she's come for her baby's 6 weeks vaccinations, and she just remarks to you that she's finding motherhood difficult. She just doesn't feel like she's doing very well, and she thinks she might have postnatal depression. She talks to you about breastfeeding being a struggle, feeling anxious at times, and generally not enjoying the baby as she thought she would. You ask her about her sleep and appetite, and as expected, she isn't getting a lot of sleep, being a new mum, but you notice she's blaming herself for motherhood not coming naturally. She says that although her husband helps her a lot by keeping the home tidy, doing washing and cooking, that he doesn't really understand what she's going through. In fact, she later tells you that they have been arguing a bit more than usual around baby not settling, and she says it's probably because they're both really tired and picking on each other a little bit more. She comments that he told her she is ungrateful. When she's raised feeling lonely, he is disparaging of her family, saying they were never there for her when she was a teen in distress, and tells her that he's the only one that has ever looked after her. You remember that excellent webinar you went to a few weeks ago on domestic violence. And although a lot of this seems to be normal adjustment to new parenthood, you decide and you think to yourself, I'm just going to ask a few more questions just to make sure you haven't missed anything before going down the antidepressant pathway. So your intervention. So number one would be to explore potential domestic violence concerns and ask direct questions. So you ask a bit more about her husband and what are they arguing about? You ask her what makes us upset about the arguments. She says that on one occasion, he made her feel like a failure because breastfeeding was so hard and baby was unsettled. He's also made comments about her losing her baby weight. Amy says she can't talk to him about how she's feeling because he has remarked on many occasions about her past depression as a teen and has often said that's the cause of their fights, and it's mostly because of her moods. She has not told anyone about the relationship issues because she felt it was normal to argue and that she was to blame for most of it, given her insecurities and being an anxious personality. So number two, explore her current and previous and current supports. Now, the couple has gone to relationship counselling before the pregnancy, but she found that this only made things worse as he got angry after the session. And what she said in the session made him give her the silent treatment for 3 days afterwards. She also felt that he didn't take responsibility for any of the problems. She says she doesn't talk to anyone in her family about how she's feeling because she doesn't want to worry them or come across as a failure to them, as they had initially some reservations about how he had treated her. She says she has a neighbour who's very caring and who she can go to in an emergency, but she hasn't mentioned anything to them. And let's explore her main concerns. Basically, she feels as though she is walking on eggshells when he is home. To make matters worse, he has now been stood down from his job due to COVID-19, and the arguments have worsened as they are together all day. In conducting a risk assessment, you would ask her some more questions around threats, physical violence, whether she feels safe, and consider the domestic violence safety assessment tool that we talked about. Based on your responses, based on her responses, you discover that he is in fact threatened to kill her if she leaves him in the past. She says he hasn't done that for a really long time, but for her, it's still a really current threat. He has once taken her keys when they had an argument, so she couldn't leave. And he has also set up location services on her phone so he knows where she is all the time. You validate her concerns and reassure her that she is not to blame for his behaviour. You name it as emotional abuse and constituting domestic violence, even though there has not been any physical violence. She says she's safe to go home, but she would agree to some counselling. So what's important here now is safety planning. So remembering you don't have to fix this. You need to provide initial support and a supportive backup and a supportive plan to link her in with some ongoing counselling and maybe a follow-up appointment with you quite soon after her first session to see how it went. Provide some information about escalating risk, what she could do if things were to escalate even more, and if she felt unsafe, who would she call, where would she go? Now, if, however, Amy has disclosed high risk indicators, multiple risk factors, you would explore things further. So in this situation, for example, in the event that Amy has disclosed an incident of physical violence, for example, she may disclose that on the previous night before seeing you, there was another argument. She shows you a small bruise on her wrist, which looks like it could be fingerprints. She says he held her wrist tight and yelled at her, scaring her. She says the baby's not been harmed and was sleeping at the time. Now, it's really important that I point out that having a child protection seminar is a whole other seminar, and domestic violence, when living with domestic violence, it is categorised as a child protection risk. So absolutely, you would need to look at child protection factors in this scenario, but that's for another seminar, and that would, require a lot more information and discussion and education. But absolutely, we would not ignore the fact that there is a baby in this situation. So in safety planning, now that you have seen this bruise and you have talked to her a little bit more about the incident, You discuss her options to go to the police, but she doesn't want to. She's keen to go home, but she's really thankful for the discussion and she agrees to a follow-up appointment with you. You provide her with the domestic violence helpline number, which is a 24-hour number, and you tell her that help is also available at the local hospital emergency department, where there is a social worker there 24 hours to talk to. You phone the safety action meeting coordinator to get some advice, because you're quite concerned about all these risk factors. The SAM coordinator is able to offer support, and at the follow-up appointment, you contact them again with Amy. They refer her for counselling and they're able to help her with some further information about domestic violence, her options, AVOs and assistance. And at that point, it may require to be discussed at the safety action meeting, and the SAM coordinator would continue to follow up with Amy. So all of this might not come out in one appointment, of course. Might be a long time before she tells you. It might be several appointments. However, and I think Jenny touched on this as well, she knows that you're there to listen. She knows you haven't judged her, and she knows that you believe her.
Thanks, Christina. So what's available within our LHD? So if you're wanting to refer someone to counselling services within New South Wales Health, in the South Eastern Local Health District, we have the St George Sutherland Domestic Violence Counselling Service, which offers free individual and group counselling sessions. Unfortunately, there is a wait list at the moment. However, that's not to discourage you from making a referral, as we do prioritise higher risk cases. So that counselling is provided both at the Rockdale Community Health Centre and at Caringbah Community Health as well. In terms of the northern kind of sector of the LHD, the St Vincent's Hospital now have a domestic violence counselling service as well. Again, that's a free service. And then otherwise we'll look at some of the NGOs in the area. In terms of sexual assault, if someone's disclosing sexual assault, we have the Southern Sydney Sexual Assault Service, which is based at St George Hospital. And for the northern sector, we have the RPA, DV and Sexual Assault Service. So it's really about where someone lives and where they're located, about what services they might be able to access, and that's kind of a bit of an issue within health at the moment. There's things that are not quite consistent across their whole LHD. In terms of NGOs that are available, so in the northern sector, there's the Delhi Women and Children Centre, which offers free individual and group counselling. They provide some childcare so that women can attend those appointments. As does Bondi Beach Cottage as well, to individual counselling and provide some childcare around that. More practical kind of support, we've got Wayjet in Redfern and Moving On, Moving Out, which also provides some accommodation support. If you're only going to be giving out one contact number for NGOs, then that would be the Domestic Violence Helpline. And they would have access to all of these different services depending on what someone's need is, and they'd really be able to link them in with the most appropriate service. So that kind of the one-stop shop really for domestic violence support, and really your starting point, unless you know that they just want counselling and you go to one of these kind of more specific services. And then down south, there's a range of different services, case management support and practical support. So that's the end of our presentation. I guess what we really hope that you'd be able to take away from today is understanding that your role is really important, that you've got an opportunity when someone is in front of you to really make a difference and support them as best you can, and that there is help out there within our LHD. So if you're not sure and you're nervous and you like Jenny said, you don't ask the questions because you're not sure of what happens if they say yes and where do I go for help. we're hoping that these pathways that May will kind of talk you through will give you some support. Otherwise, you're more than welcome to always contact us as well within New South Wales Health.
Thanks so much, guys. That was great. So today actually came about because I have been talking to Marae and Christina about the health pathways pages on domestic violence, and realised that even though I've worked as GP for a few years in the area, had no idea about safety action meetings or any of the local services that I could refer patients to. So that's why we thought we'd put together. Now, I just thought, let me just try and put this away. I would try and show you guys really quickly before we go to the questions, of which there's quite a number of good questions. I just thought I'd show you guys really quickly what Health Pathways is and how you can use it to not only look at domestic violence pathways and how to link patients up with services, but also just to use them for other general practice stuff. So this is our homepage. If you Google Southeastern Sydney Health Pathways, it should come up, and the login is the username is SE Sydney, and the password is healthcare. So, and if you're ever not sure, just ask your friendly PHN and they'll give you the passwords for whichever Health Pathways page is relevant to you. So if you're within this central Sydney area, it's actually just Sydney and they've got their own password. But this is Southeastern Sydney's page, and it brings you to the home page. And there's a few handy things here just to know about. There's like any recent health alerts from the PHN will come up here. Any recent pathways that have been localized will come up here, and you can find out more information about how to use Health Pathways down there. But just to show you about the domestic violence pathways, if you search at the top, it'll bring up a list. And just for the purpose today, since we've been talking so much about safety planning, I'll just show you quickly the safety planning pathway, which we've been working on, and it's essentially just it has run through a lot of what we've talked about today. So in terms of assessment, if you want to use the domestic violence safety assessment tool, there's a link right there that goes directly to the actual PDF, which you can work through with some women. If you don't have time to do a full CV side, or if it's not clinically appropriate, there's also a drop-down box sort of summarising the key things that we need to be sort of asking about or being mindful of when we're assessing a patient's level of threat. And in terms of referrals, okay, let's say you decide you want to refer someone to a safety action meeting, or you just want to talk to them, you can skip down to the request section, click through, and this is a request page. So it just sort of has the list of all the referral services there are in the area. So if you wanted to, for example, get advice about a matter when you're not sure whether you should be reporting to the police, there's domestic violence liaison officer contacts. There's information about how to arrange urgent accommodation, but most importantly, the safety action meeting pathway information is here. So there's a few little drop downs to click, and if you actually want to not click down too often, you can actually use this to open all, but I'll just talk you through. So there's a referral form and the safety assessment tool again, and these are the contacts for the local safety action meeting coordinators, and they're actually I sort of found really good resources, or a good person to talk to if you're not sure whether or not you need a referral necessarily, and if you want to sort of get some immediate phone advice. I think that's a good option, as well as of course the DV help support line. So the other thing that I thought I'd make everyone aware of, as I learned doing these pathways, is actually domestic violence victims or abuse survivors are actually eligible for 22 hours of free counselling through victim services. So if you sort of know your patient, you know, either was a previous victim and still affected by that, or is currently in an abusive relationship, you can get them a sort of ongoing counsellor through victim services, and there's all the information that you need for the referrals there. And the final thing I'll show you is that we're always trying to improve the pages, and there is a option here to send feedback. So if there's ever anything like a broken link or a resource that you think should be included, please click send feedback, and it'll bring you to a page where you can give us some information, and we read all the feedback that's sent through. So please do let us know how we can improve. So that's that. That's all from me, and now to questions. So I'm just going to try and open up the question box, but the first one that came through was about emotional abuse. How do you manage emotional abuse, and because there's no law to change it or to charge, and police, you know, seemingly aren't able to help? What's your advice in regards to that, guys?
I just want to say that emotional and psychological abuse sometimes is more damaging than just about any other kind of abuse that occurs. It might sound strange, but it is. And so I think you would manage it in the way that you would manage anyone who's been through any kind of traumatic event. It is trauma. And so that's how I would manage it. And, you know, again, it would be the same thing of putting, you know, their emotional safety is at risk. Sure, it might not be their safety, but their emotional safety is. So again, I think referrals, and I forgot to mention, I actually try really hard to make warm referrals, meaning that I actually, when the patient's with me in the room, I say, hey, I think it would be a great idea if I phoned up this organisation who can maybe have a chat to you on the phone and help you out. Are you okay with that? And I actually do it rather than just give them a phone number. So yeah, I would do that also in this situation. Yeah.
Okay, great.
I think one of the things is that emotional abuse is so, it's hard for the victim even to identify that that's what it is. And so much of the focus of media on domestic violence statistics is around physical abuse. So really highlighting when you're seeing that person that is in fact domestic violence, even though there's no physical evidence of it.
Yeah, and knowing, I guess, letting the woman know like what she should be able to expect from in a relationship and what is not, you know, something that she should tolerate. Thank you for that. Another question was, other than the obvious signs, how do you recognize or how do you suspect abuse in the clinical setting, and what are the red flags? I suppose we've been there, we sort of touched on that a bit. Is there anything you'd like to expand on in that regard, anyone?
I think I've sort of mainly said the things that I get concerned about, but look, I just think anyone that you kind of go, oh, you know, is there something else going on? Am I missing something here? You should ask about domestic violence. That may well be it, because it's so common. So if you think you're missing something, you probably are.
Yeah, just go with your gut feeling.
Trust your gut. When it comes to domestic violence, it's often you feel it, you know there's something just awry or amiss, and all it takes is a couple of questions, and it might not get a disclosure that time. It might take them a year before they trust you, but you're, you know, starting to open up that channel.
Yeah, just being able, just like putting yourself in a place where they know that they can come to you, I think is so valuable. So the other question is, how do you think general practice can best incorporate, I guess, domestic violence screening into routine visits? Is this something that all GPs should include as a part of every consult?
Look, there are pros and cons to doing it, and certainly in pregnancy, they're very much encouraging people to do it, particularly because of the known escalation in violence. So you should certainly be screening every pregnant woman that comes in. There's no current guideline from any of the main organisations or the RSEG White Book to recommend screening every single person. But look, you know, if you'd like to start asking all the people that come in your door, you're going to identify lots of cases. So maybe it's not such a bad idea. But there's no current guideline in.
Yeah.
I guess as a guide within New South Wales Health, we do have policies around mandatory screening, and we've got the routine screening program, and that's for any females over the age of 16 presenting to mental health, drug and alcohol, antenatal or early childhood services within our health district. And they're also doing some pilots around emergency screening within the emergency setting as well at the moment.
And does that fall on the doctors seeing the patients in that setting, or is that something that if they're presenting they'll flag it to social work and that's something that's asked about them?
No, it's the responsibility of the clinician, so whoever's seeing that female at their initial appointment.
Yeah.
It really could be anybody. It could be the triage nurse, it could be the doctor that sees them, it could be anybody that might pick up on an indicator.
Okay, perfect.
I think the benefit of the GP asking is that the GP often has a relationship with the patient. And so I actually think that means that patients are very likely to disclose if a GP asks who knows the patient. So, I mean, there could well be benefit in it.
Yeah. Another one is, what symptoms would you expect to notice in children, for example, living in a domestic violence environment?
I think witnessing domestic violence is in itself a form of child abuse, and should be reported to DHS, if that answers the question. But of course, then you'd look for all the normal things that you look for in a child that you're worried is being abused themselves. A child that, you know, acts strangely with their parent, or is showing sexualized behaviors, or obviously physical signs of abuse in the child, or, you know, those sorts of things as well. But just the very fact, like the 7-year-old I was talking about, I mean, that had to be reported because she had likely witnessed child abuse, a domestic violence, and that in itself is abuse.
Just in the hospital, just from a paediatric perspective in the hospital, we've seen all age ranges and different effects and different impacts of DV on children, ranging from newborns with failure to thrive, and, you know, after asking a few questions, pulling the mother by herself and talking to her privately, we found out, you know, just an example was one where every time she would breastfeed, her husband would stand over her and berate her. Now that baby couldn't tell us, you know, I'm impacted by this violence, but it showed it in that, you know, not being able to feed properly and not putting on any weight. So that's just one tiny, you know, but there are obviously the behavioural issues in older children, and witnessing and then coming to accept that behaviour is normal and then displaying those same behaviours.
And in teenagers, I think mental health issues, depressions, self-harm is a really big one as well. Yes. We really should be screening all of our teens for what's going on at home. So, yeah.
And the final question.
And also just to point out, that also even within a family, you'll have, you know, if you had 3 children, they'll all be displaying different things, so that it's really going to be impacting them differently. You might have the older child, you know, taking on a parental role to protect the younger ones. The younger one might be the favourite of mum, so, you know, the baby gets the, you know, the abuse from dad more directly. It really is a case-by-case example, and it can, you know, really kind of bring up a whole range of things. And also just a quick point that even if the child's not in the room, even if they're not witnessing, like actually seeing the violence or experiencing it themselves, they are still going to be impacted by what's happening within the household.
Yeah, definitely. So the final question before we wrap up tonight is what support can we provide to a parent with an abusive child under the age of 18 years of age?
Oh, that's a tough one. I've had that one recently in amongst the whole COVID thing. So I've got a 12-year-old child who has been like actually really harming his mum to the point that she's worried for her safety, and he's only 12, so she's got to look after him. It was really hard, so I called the local hospital to try and get the youth mental health team involved. They said, no, this is domestic violence, so this doesn't come under us. So we've then gone to domestic violence organisations who say, yeah, but what can she do? She can't take out an IVO against her 12-year-old, and she can't just leave him to go on the street. But it turns out that I explored this option with a lot of other GPs on the GPs Down Under group, and we sort of workshopped it. What can you do? And really, the only real option, if it was she was really worried for her safety, would be for DHS to take the child and place him somewhere else. That would be the only option if we were really concerned for her safety. So look, you know, at the moment we've, you know, things have settled a little bit, but you know, I mean, this kid threatened to kill his principal and tried to strangle his mum, and just, I mean, really out of control.
That's awful.
I mean, obviously that's the worst case scenario of removing him from his family. That's you know, that would be difficult for everybody, wouldn't it? But you would, you know, my first thought is there DV, first of all, between the parents? That's what I would be assessing first, to say, is this a behaviour that's coming from domestic violence in home? And then after that, looking at, rather than a legal or legislative approach, legal policing response, I guess, looking at what supports can be put in place, and does that child need to be enrolled in a school that manages behavioural difficulties, and what other family support services can be put in place as well to support them. It's not, I mean, it's not ideal, obviously.
It's really hard, isn't it? Look, we'd maximised services that we had youth workers, and we had all sorts of different people involved. He had oppositional defiant disorder, and well, mum, I've asked, but mum has never disclosed domestic violence. But you're right, it just does smell of it, doesn't it? You do wonder. Yeah, very tough situation though.
Really, really hard. Oh, and okay, we've got a final question from Ada Chen. If a patient doesn't want to see counsellors or make a police report, but has made a disclosure to you, should you still make a report if you think she's at risk? Which is a tricky one. I think we've talked about this briefly, like just in writing the pathway. What do you guys think?
I know that in New South Wales Health we have sort of some guidelines around when you report to police with or without the consent of the patient, and that's around very serious injury. So if there's a broken bone, if there is a gunshot wound, a weapon's being used, a laceration, that's very serious. You do not require the consent of the patient. But obviously it's ideal to get the consent because you want to carry them on that pathway with you with support. But we do not have to, as New South Wales health workers, we do not have to report to police if there is no really significant injury or significant threat to kill.
I absolutely agree with that. I think that's very true. Look, it would be a very rare scenario for you to get someone that was at such imminent risk that you felt like you had to call the police against her will. I think that would be very unlikely, but it is possible. And look, again, just quoting the RSCGP White Book, they make it clear that if you believe that a woman is at imminent risk, then you should absolutely be calling the police, even if she doesn't want you to. And I think it's backed up in the legislation that you guys were, Christina and Muriel were saying before. Yeah. There is no mandatory reporting of domestic violence except in Northern Territory for all domestic violence, except the Northern Territory.
Yeah. Okay, I think that brings us to 8:30 and bang on time. So look, thank you so much to everyone for attending today, just to learn a bit more about